Our next speaker is a recipient of International Fellowship for Young Biomedical Scientists in 2008, and he had his fellowship at Level 1 Regional Trauma Center in Tampa and R. Adams Coley Shock Trauma Center, Baltimore, Florida. He was a visiting faculty fellow in trauma and surgical critical care at University of Michigan, and he is also an academician with over 150 publications. And his interest lies mainly in trauma and injury epidemiology, trauma systems, to name a few. He is a core group member of the National Disaster Management Authority in India and is a firm believer of capacity building and training as the ways to improve trauma outcomes in India. He is a Fellow of the Royal College of Physicians and Surgeons of Glasgow, Fellow of the American College of Surgeons, and Fellow of the International College of Laparoscopic Surgeons. He is the Professor of Division of Trauma Surgery and Critical Care, JPN Apex Trauma Center, All India Institute of Medical Sciences, New Delhi, India. Please welcome to deliver his lecture on the recent advances in vascular injuries, Professor Amit Gupta.
Thank you very much, Dr. Gatmaitan, for this kind introduction, and I hope I'm audible and the presentation is visible to all of you. Um, well, first of all, let me thank the chairman of the ACT, Professor Rolando de la Cruz, and also my dear friend, Professor Chuman Trek. I wish him a very happy birthday today. I must also thank Ms. Rense, who has been working very hard to make this active first webinar extremely successful. I'll be talking today about peripheral vascular injuries, the current management and recent advances, and I've fashioned my presentation in a way that will aid the young budding trauma surgeons or vascular surgeons about peripheral vascular injuries. I would not be, going in detail about the endovascular because already Dr. Raj and Meena Cheng would be talking about endovascular procedures. So let me just, sort of introduce the topic with a few case scenarios which we had in our trauma center, just to give you a view that peripheral vascular injuries can present in many, many different ways and at different time periods. The first case, a 40-year-old man had an assault with an ice brick. He presented to our trauma center in about 7 hours. After the injury, a quick assessment, patient was talking, coherent, conscious. He was still triaged as red because of the penetrating injuries. Primary survey was principally unremarkable. The adjuncts were negative, but on secondary survey, we could see an ice-pick injury which was in line with the major vessels of the upper limb. His left upper limb pulses were palpable. There was no neurological deficit, but that subtle soft sign of the injury, penetrating injury being in the line, we got the CT angiography done, and you can see a discontinuation in the axillary artery. Surgical exploration was done, and the artery was repaired. Let's come on to a second case. This case was a case of gunshot wound in the right thigh. Initially taken to a local hospital, the foreign body was removed, and he still had intermittent bleeding from the entry wound. He presented to our trauma center after 17 days, a delayed presentation of this injury. He had intermittent bleeding from the wound. Primary survey, obviously, after 17 days was unremarkable. There was an entry wound posterior medial aspect, no exit wound, and we got a CT angio done. And you can very well see a large pseudoaneurysm here, along with the early filling of the veins, denoting a arteriovenous fistula. What we did so was a DSA, and you can see the pseudoaneurysm here was stented by endovascular procedure, and there is no leak into the vein now. The third case, a 15-year-old male patient, pedestrian hit by a truck, arrived very early, within an hour after injury. His 10-second assessment, patient was drowsy, incoherent, confused. He was again tried to red because he was in hemorrhagic shock. The primary survey showed that he was in class 3 to class 4 hemorrhagic shock with an unstable pelvis, and the distal pulses of the right lower limb were absent with a right femur fracture. Obviously, he was a non-responder, and therefore he was taken up immediately for pelvic packing and external fixation of the pelvis. Along with that, we had to do a temporary shunt placement of the SFA because the physiology of the patient was not, sort of giving us time for a definitive repair. Later on, the patient was shifted to ICU, and finally, a relook surgery for a definitive reconstruction of the SFA was done with the vein graft. So this was just to tell you that the vascular injuries per se can come to you in various shapes and sizes and at various times of presentation. Well, our talk outline would be just to give you a brief, sort of introduction to the epidemiology, the types, patterns, and natural history of vascular injuries, how to diagnose it clinically, and what are the imaging modalities available, what is the definitive management in terms of the vascular injuries per se, and how to do post-discharge surveillance, and what are the few recent advances in vascular repairs. Well, vascular trauma is generally 1 to 2% of all civilian trauma, and our center is also a civilian trauma center. But most of the vascular injuries are not treated in smaller hospitals. They're generally referred to a bigger trauma center. And this causes disproportionately high morbidity, mortality, and also loss of time before the time an actual trauma center can actually see these peripheral vascular injuries. Penetrating in the Western literature is more than blunt injuries. Lower limb is more than the upper limb. The risk of mortality is low, but the risk of limb loss is pretty high, of the order of 7 to 30%. Our experience of the past 6 years, I could dig up some data that the total peripheral vascular trauma was about 6.6% of all our admissions, which is higher than the Western data available. Our upper limbs vascular injuries were more than the lower limb vascular injuries. The average ischemia time was about 6.5 hours because these patients were generally referred from a local hospital or other outside hospital. The amputation rates in our center, where we did a vascular repair, was about 13% as compared to the literature, which is about 25 to 40%. The injury profile, upper limb, as I said, was more of brachial artery, followed by radial and ulnar. In the lower limb, majority of them were popliteal arteries, followed by femoral arteries. Well, what are the types and patterns of peripheral vascular injuries which a trauma surgeon or a general surgeon can see? Well, obviously, when the injury occurs to a vessel, it can either lead to a thrombosis of the vessel. That means there is some injury to the intima, which leads to coagulation of the blood inside, or there can be a spasm due to some blunt trauma, or it can lead to disruption of the artery leading to hemorrhage. In special cases, there can be AV fistulas also. The blunt trauma generally leads to intimal defects and spasms, that means thrombosis and spasm, whereas penetrating trauma generally would lead to wall defects, complete transections, or arteriovenous fistulas. This is just to schematically and photographically show you how intimal injury can produce a contusion, or if there is a proper intimal injury, then it can lead to thrombosis within the vessels. It can lead to stretching and contusions of the vessel, leading to segmental spasm. It can also lead to hemorrhage, as I said, complete lacerations or simple lacerations, or in special cases, formation of a pseudoaneurysm where the adventitia is still intact, or rarely, especially in penetrating injuries, can lead to arteriovenous fistulas. And you will see this was one of our cases having a communication between right renal artery and the renal vein. Pattern, again, as I said, right from blunt injuries affecting the bony structures and causing injuries to the vessels, to deep incised cuts leading to lacerations of the vessel, or in a delayed form, patients can present with large pseudoaneurysms. This was one case of a profunda femoris pseudoaneurysm. The natural history is not very good. So if left untreated, especially after the initial hemorrhage is controlled, it can lead to either ischemia or thrombosis, or because of thrombosis, or lead to rupture of a pseudoaneurysm later on, or at times, Steele syndromes can occur, leading to heart failure at a very late stage. So because the consequences of vascular injuries, even peripheral vascular injuries, are pretty serious, so we should not miss a peripheral vascular injury coming to our center. It leads to functional disability and also might lead to loss of limb. So how not to miss an injury? Have a high index of suspicion. Give due importance to the mechanism of injury, how the injury has occurred, what is the trajectory, if it is a penetrating injury, is there a relation with the vessels or nerves, and do a good, careful physical examination. But I must, warn you that examination alone sometimes can be deceptive, especially if the distal pulsations are present, and therefore use investigations or adjuncts liberally. So, how to diagnose peripheral vascular injury? So ask yourself, was the injury blunt or penetrating? Is it an arterial injury or can be it a venous injury? Is it causing bleeding or ischemia? And should I take the patient to the operating room? That means, is the patient hemodynamically stable or unstable? Definitely, clinical examination is very, very important. Just to give you a brief history, the indications for exploration of a presumed arterial injury was initially reported by Sinclair and Spencer in 1960, where they gave certain signs of vascular injuries where exploration was a must. But it was not until Snyder wrote the chapter in Rutherford's second edition in 1984, and he gave the names hard and soft signs, that it was known to the world as hard and soft signs of peripheral vascular injury. Well, the hard signs being pulsatile bleeding, expanding hematoma, absent distal pulses, cold pale limb, palpable thrill, or an audible bruit. This was given in 1992 by Freiberg, and Freiberg said that if these signs are present, do not wait for anything else. This should prompt immediate surgical exploration. But the problem is that the presence only of hard signs cannot localize the defect, especially in where there are multiple injuries at multiple levels in a vessel or multiple fractures leading to. And therefore, he said in his paper that the surgeon's armamentarium is either a duplex scan by an experienced surgeon in the OR or a surgeon performed arteriogram in the OR. These are the days where CT angiography was not very, so about 28, 30 years back, CT angiography was not that common in all the centers. Well, he said soft signs like peripheral nerve deficit, moderate hemorrhage at the scene, reduced pulse volume, or injury in proximity to major artery can also be taken as signs of vascular injury. And if the soft signs are present, the injury actually ranges from 3 to 25%, and out of which 1 to 4% of patients would have absolutely normal physical examination findings. So beware, if you're finding soft signs, go ahead and use your adjuncts liberally. So what are the clinical adjuncts available to a trauma surgeon? Well, there has been a lot of literature about the arterial pressure index. That means distal pressure of the limb, affected limb or the injured limb as compared to the uninjured limb. And an API of less than 9 has a very high sensitivity, and therefore, if everything else is normal and the API is more than 9, probably you can safely discharge the patient. But with a caveat, because API has got limitations. It only detects injuries to the major axial arteries, not arteries like, for example, profunda or any other artery which is not in the direct axial line of the vascular structures. The lesion, it cannot find out minor intimal flaps or pseudoaneurysms. It has got limited value in massive soft tissue injuries, hemorrhagic shock, and complex fractures. So if doubtful, the other armamentariums available, if you don't have ultrasound in your ED, nowadays most of the EDs in trauma centers or bigger hospitals would have a high frequency probe. You can directly see the artery distally, palpating or not palpating, or you can also use a handheld Doppler, which I think is just like a stethoscope, and all trauma and vascular surgeons should have one handheld Doppler. Well, does the distinction between hard and soft signs in today's world, where we have good imaging technologies, still of any value in planning definitive management? Well, I would say it is slightly obsolete now, because it was founded more on observation than any objective data. And the AST Prove It database, the prospective observational vascular injury treatment database of the AST, they recently analyzed it and very clearly said that using hard and soft signs as a decision-making strategy is now outdated. But probably these all adjuncts can be used in places where you have a suspicion and you do not have, CT angiography or other and Asian countries, definitely smaller centers would not have readily available 24/7 CT scanners. Well, imaging, the literature is very, very clear. The East Practice Guidelines, level 1 evidence, almost 100% sensitivity and specificity of CT angiography. And the advantage is that it can be performed with other CT evaluations. Obviously, if the patient is hemodynamically stable, if you need a torso CT, you can do a torso CT, abdominal CT, along with the CT angiography of the affected part. So that's the added advantage. Conventional arterography, no role except for if you do not have a CT scanner and CT angio, or maybe those places where there are multiple pellet injuries or a limb fixator is there, which is giving rise to a lot of artifacts in a CT scan. Coming on to the definitive management, I'll just dwell upon a little bit on the endovascular management role in the peripheral vascular injuries. Well, there has been a gradual shift in the paradigm of using selectively the endovascular techniques in peripheral vascular injuries. It's not replaced it, but it can complement definitely. And the techniques can be embolization of a pseudoaneurysm, balloon dilatation of a spasmodic artery, or a covered stent for AV fistulas or disruption of arteries. Well, again, data analysis from NTDB data does not significantly show any differences in the amputation rate, mortality, or days of hospital stay. And moreover, the concerns of endovascular stents are the compromise of mechanical integrity, long-term patency of grafts, especially in areas of groin and thoracic outlet, relatively smaller diameter leading to stent thrombosis and late restenosis, requirement of long-term anticoagulation. But still, the scope of endovascular management in peripheral vascular injury is good if there is difficult surgical access, if there is high probability of complication of surgery, risk of neurological injury while doing surgery. You can also use it for balloon occlusion, temporarily control the hemorrhage in the distal artery. Proximally, you can inflate a balloon, or you can have a management in post-operative complications. The emerging concepts of endovascular resuscitation are also there, like RIBOA, SAP, and ECMO. I'll not go into the details. Dr. Meena Cheng would discuss RIBOA in details. But this one thing can be a very, very handy tool. A hybrid operating room or a Raptor suite can actually replace the three places in your hospital: a resuscitation bay, operating room, and an angio suite, which is combined together in the Raptor suite. And therefore, you could do procedures, you could do endovascular procedures, you could do open procedures all and resuscitate the patient all at the same time. Well, still, open surgery is the primary mode of management in peripheral vascular injuries. Well, open surgery historically has seen a paradigm of change from simple ligation of the arteries, especially in the pre-antibiotic era till the 50s. In the Korean and Vietnam wars, repair replaced ligation, and then gradually vascular trauma surgery has come up in civilian hospitals, and limbs are being preserved after arterial surgery in more than 90 to 95% of cases. So you need to do a good pre-operative preparation. You can give heparin in the ED itself if you see ischemic signs. If there are no contraindications, if there are contraindications, you can use local heparin during the procedure. Always remember to over-prepare and over-drape so as to include the area of proximal control, the entire extremity, and also at the beginning itself, try to plan from where you can. I mean, if needed, you can take a vein graft. Well, operative strategies are obviously proximal and distal controls. Handle the adventitia as little as possible. Be ready with a Fogarty catheter. You might have to do a thrombectomy, note the backflow, and assess the amount of tension. Now, tension-free repair is very, very important. At times, if there are only thrombus, you might have to do a arterotomy proximal or through the injury site. The incision should be transverse, preferably, and the closure of the arterotomy is later on done interruptedly. Put in a Fogarty catheter, generally 3 French in brachial, 4 French in femoral or popliteal. Check the balloon, insert, inflate, withdraw, and withdraw multiple times till the time a good backflow is achieved from the distal end of the artery. Now, choice of repair can be primary depending upon the extent of damage to the artery. It can be resection and anastomosis with an end-to-end repair, or if the distance is more than an interposition graft with a vein or a prosthetic graft. In our center, we do a lot of end-to-end anastomosis, more than 62%, followed by reverse saphenous vein grafts and thrombectomies. we use synthetic grafts in only about 2% of patients last 6 years. Now, primary repair, incomplete rent, no contusions. You can go ahead and do either continuous repair or interrupted repair, whichever suits you and you are better trained in. But you might have to do, especially in blunt trauma, a segmental resection and then repair. But remember, the repair should be tensionless. Bring the edges together, properly aligned, see for tension, change the position of the limb, mobilize by ligating the branches, and take control of named branches. Probably most of the cases you would end up doing an end-to-end anastomosis. The end-to-end anastomosis, just a word, was the three-point anastomosis was popularized by Alexis Carrel. He was the second surgeon after Theodore Crocker to receive the Nobel Prize in 1912. And he not only, sort of gave us the three-point vascular anastomosis, but also was the father of transplant surgery. So other techniques are also available. I would say that the technique depends upon the size of the vessel and the comfort and ease of the surgeon. So it can be 2-point, one continuous and one interrupted. It can be, if it is large caliber, you can go ahead and do it continuous both the sides. If there is a caliber mismatch, you can spatulate the ends and then take anchoring sutures and then repair, again, either continuous or interrupted. Just a few photographs to show a brachial artery repair and a popliteal artery repair. It is very important to assess the repair intraoperatively because there can be certain issues like, sort of twisting of the arteries. And in 10% of the cases, there are certain technical issues. So always see distal segment for pulsation. If you cannot find, you wait, you give some papaverine locally or xylocaine, see with a handheld Doppler. Literature also mentioned completion and arteriogram, but we've never tried a completion arteriogram because we don't have services of an angiosuit inside the OR. So interposition grafts can be used. They're not preferred, but they may avoid sacrificing of important branches for mobilization of both the ends. And the grafts can be native veins or it can be a synthetic graft. If vein grafts are used, generally autologous vein grafts from uninjured lower extremity are first choice because saphenous, short saphenous, cephalic, or any other local vein if you can find. Vein grafts, again, important is the important part is that it should be atraumatic and the lysis of advential band should be done. Minimal handling of the vein. You can flush it with buffered isotonic solution. You can also prepare it with heparinized saline. Synthetic grafts, we've used PTFE and Dacron both. Dacron is slightly better than PTFE because it is knitted and has better compliance. But nowadays, new collagen-based and PU polypropylene grafts are also available. Graft failure rate, yes, it is a concern. 5% early graft failure, midterms about 6 to 24 months, about 10%, and late because of atherosclerotic disease. But always, autologous vein graft is better than synthetic vein grafts in various series and various literature. Soft tissue cover is essential for preventing desiccation, infection, and sort of secondary hemorrhage from the suture site. You can use local muscles, you can use advancement flaps, but complex flap repair should be deferred for a later date. Post-operatively, do good surveillance, preferably with the duplex scanning. And it is very, very important to see the flow through the repair which you've done. Just a word about damage control vascular surgery. As we had done in one of the cases, if the physiology of the patient is disturbed and is precluding definitive repair, you can just put in any temporary shunt between the two ends of the arteries and do shunting and probably do fasciotomies in the distal part. The temporary intravascular shunts, the literature says that it has lowered the rates of amputation during early phase. If it's used in early phase, vascular shunt should be a part of more aggressive approach. What are the operative adjuncts? Should we use systemic intraoperative anticoagulation or not? There was a recent article, a meta-analysis, in fact, of 7 retrospective studies having more than 1,300 patients. And they said that there was a significant reduction in negative outcomes, lower amputation rates, and no increase in risk of bleeding if you use systemic intraoperative anticoagulation. Distal fasciotomy, we routinely do if we have prolonged ischemia time, if we have closed fractures or crush injuries or combined AV injuries. We normally would not do pressure measurements, but if we are suspicious of any one of the preemptive problems, then we do a distal fasciotomy. Well, coming on lastly to the future directions of vascular anastomosis, there are many things coming up. I think Dr. Raj will take you towards this direct site endovascular repair, where sort of conventional expandable endovascular stents have been used in an open manner. It avoids complicated anastomosis, it saves time, and it also can be used as a salvage procedure. Well, endoluminal laser-assisted vascular, or LAVA, as I said, the research actually started in early 70s and 80s. Various lasers have been used, and protein solutions are used at the ends of the arteries, something like this, like albumin used as soldiers, and then laser beam sort of coagulates the proteins with subsequent cross-linking and collagen formation. Another thing is using polyxamer nanogels. Basically, these gels give a frame. They are injected into the two ends of the arteries and they solidify, over which the artery can be repaired. And then later on, when the body temperature is reached, these gels again become liquid and they flow into the arteries. So it avoids anastomosis completely. Then one case has been reported in literature for bioengineered human blood vessels. Obviously, this is the future. You have a biodegradable lattice over which there is cell culture of vascular smooth muscles, which forms, and then the lattice degenerates, giving you a perfect sort of artery or vessel. Well, finally, the take-home messages are peripheral vascular injuries, you should diagnose early, and the surgery is key to successful outcomes. Minimize the ischemia time. Clinical examination findings at presentation must take precedence, but again, clinical examinations is not complete. You should use liberally CT angiography if it is available. Tensionless repair is paramount. Damage control surgery, use of shunts is both limb and life-saving at times, and intraoperative anticoagulation finally improves the outcome. And I must acknowledge the whole team of the JPN Apex Trauma Center, my fellow colleagues who are shown here, and especially Dr. Soumya Ghoshal and Supreet Grewal, our senior registrars of trauma surgery, who've done a fair bit of research for this presentation. Thank you so much. And I'll take up questions later on.